Hi, good afternoon, Dr. Garima here. And yes, as much as I was meaning to shoot one scenario every day, things keep happening. Been back from Mumbai since past 10 days. My son down with viral. Eventually, I'm down with viral. At least I can speak today properly. And I've been working non-stop in the clinic. So, just have few minutes now. My son started his first day of school. Wow, he's grown up. I thought let's just might as well shoot a video since I have the next 10 minutes with me. And of course, I respect and I really appreciate the comments that you have been leaving on YouTube and my personal Instagram, asking me to shoot more of these kind of videos, the practice paper solving from the ADC. I do not want to disappoint you all. Even I enjoy shooting the videos. It's just that there are just so many things to manage sometimes, and my husband's job is such that technically I think I'm a single parent now. So it is quite taxing with a 3-year-old, honestly. Like, I salute all the single parents. I don't know how you all do it. And I think I have to start watching some YouTube videos on how to cope up being a single parent, honestly, when your spouse is having crazy working hours in his job, as if the entire job is their life and you can't say much about it, but the things related to children also need to be done. And it's not like I'm a housewife, I'm working myself, so it just get taxing in all the ways, but it's okay. God helps. There is help, there is courage, there is the will to do the things the right way and to raise the son properly. So here I am, and there's a will to help you all as well. Let's start solving right the next scenario of Australian Dental Council written exam. This is a practice paper released by them, and I'll be solving scenario number 8. And it's a very interesting scenario, and you will definitely encounter such things at least once a week in a busy practice. So let's see. Yeah, I'm gonna cough a little bit here and there. Rajesh, oh wow, an Indian male. Lots of Indians in Australia, by the way. Actually, lots of Indians everywhere in the world. We are a billion count of population, and so we are going to be there everywhere, right? Rajesh is a 39-year-old male patient who attends your clinic complaining of severe pain in the lower right molar region. Severe pain. It's not just any pain, it's a severe pain. That means something has to be done, okay? He saw a local dentist 4 weeks ago for a root canal treatment in tooth number 46, but developed a dull ache shortly afterwards. The pain has increased in intensity gradually over the past 2 weeks. Okay, so there was an RCT done, then a dull ache started, and that pain increased and increased over the past 2 weeks, and it's reached a point that he has to come to you now. He has brought a radiograph and some clinical notes regarding tooth 46 to the appointment. No other previous records are available. His medical history reveals that he has a GI ulcer, which is treated with esomeprazole, that is Nexium, the brand name, which is a proton pump inhibitor. So why is this medical history important to you? So there are many keywords here. The first keyword being severe pain. That means something acute is happening. Second thing is that his pain gradually increased and that he has an X-ray already done, which shows pretty much an RCT done. And the third thing is he has a GI ulcer for which he is taking a proton pump inhibitor. So as such, proton pump inhibitors don't have much reactivity with any other medication, but the very fact that he has ulcer, it means that you cannot give him non-steroidal anti-inflammatory. Like, it's not like you can't give, you have to avoid it until you can, because they cause more GI ulcers, or they can aggravate an existing GI ulcer. So basically what you can't give is COX inhibitors, COX-2 inhibitors, selective, non-selective, Brufen, and coxibs, etc. Those class of drugs you have to avoid. So what you can give codons like oxycodone, you can give paracetamol, but paracetamol by itself won't help that much. So either you would have supplemented with ibuprofen, but you can't give that, so that's why your option of drug should be oxycodone, which you can prescribe in Australia. So that is why that last line is important, so you don't get stuck with the medicine when you have to prescribe, or you don't choose the right or the wrong medicine, correct? So remember that last medical history is so important. So now let's go on to what clinical investigation would be most appropriate, okay, to assist you with the diagnosing Rajesh's chief complaint. So you see a tooth and you see there is no crown done, but you see it's a properly restored tooth, but an RCT has been done and you have the x-ray, and now he's having too much pain. So the first clinical look, you'll just see a tooth. The only way you will find out something is first you want to see if the tooth moves. So palpation is the key here. Your first investigation only will start with palpation. Then if you see the tooth is not mobile, that means the tooth is still intact. That means laterally the periodontal ligaments are fine. And in the first look the tooth doesn't seem fractured. Then the next thing is you're going to tap on it to see if there is any periapical problem happening. And then you will try and see if the furcation area is having some problem, or you can see some pus coming out from somewhere, so you're going to probe. These are your steps: palpation, percussion, probing for any RCT treated tooth who's going to come to you with pain. Option B, right and right, that is a test. No other option is correct. Understood? You may question why not option E, sensibility test. Well, the pulp is already gone. What test are you going to do about it? You have already have the x-ray that the nerve has been removed. So what are you going to check in sensibility test? You have no other test which gives the same answer. You may again question option number D, which is bite and release test, which is to check if it's cracked. But that you should do in a case where the pulp is vital and you want to check if the tooth is cracked or not. Or the tooth is non-vital, but not like an immediate RCT treated tooth. Like, it's not a wrong test, but it is not in my list of investigations. The 3 investigations that's given in option B, they have to be done first. Then if you have time and you want to somehow determine if it's a cracked tooth, then you can do the bite and release test. But otherwise, no. I would just go with palpation, percussion, periodontal probing. Then the clinical records regarding the root canal treatment of 4-6 indicated that an unbuffered solution, unbuffered means a pure concentrated solution of 2% sodium hypochlorite, was used as an irrigant in all previous appointments. Now, which irrigation factor most likely contributed to Rajesh's persisting endodontic infection? What this line is asking, it's saying that which irrigation factor. What are the irrigation factors? It's with what you irrigate, how you irrigate, the instrument with which you are irrigating. Are you accessing the full length of the canal, or did you go halfway through? Did you miss any lateral canals? Was your solution the proper solution to irrigate? Did you irrigate it for enough time? These are the irrigation factors. Now, what you would have done wrong in the irrigation that would have resulted in the infection not being eliminated, meaning there is still an infection going on because of which he is having pain. What is the aim here? To relieve him of pain. Now, if you see on an x-ray if an RCT has been done and the tooth is fine and there is no fracture, etc. that has happened, then what went wrong in the RCT is what you are trying to determine, because when you do re-RCT, you want to correct that problem, correct? So where things can go wrong? It can go wrong either the pulp is not extirpated properly, or maybe it's extirpated but the anaerobic infection inside the canals, it's not eliminated. And how is that eliminated? By proper filing and copious amount of proper irrigation techniques. Now, if that is not done, then you have to do that. Now, if that is done and still there is a problem, then probably the obturation is not done properly. But obturation is not so much of a problem, because if you have done the biomechanical preparation properly of the canal and still if it is short in obturation, you can still be okay. But if the bacteria only have not been eliminated properly, then it's gone, right? Then the main problem is the bacteria is not being eliminated properly, and you have to open the root canal, remove the katapacha, clean the infection. You cannot leave the bacteria inside and do a perfect obturation and assume that the tooth is gonna be okay. So that is the question is asking, which irrigation factor most likely contributed to Rajesh's persisting endodontic infection? The high pH of the solution reduced its antibacterial efficacy. No. The concentration of the solution was insufficient to dissolve pulpal remnants. No, 2% is quite a good solution. The main ingredient in the solution was ineffective to kill gram-negative anaerobic rods. No, 2% sodium hypochlorite is quite an effective one. The solution accessed the canals incompletely. The solution extruded through the apices. Okay, now let's explore option D and E. A, B, C are wrong. Option E, the solution went through the apices. Well, if that would have happened, he would have had pain immediately. Like, he's not going to have pain like 4 weeks after the RCT. He would have had immense pain instantly, which eventually would have settled down. But here, the pain started 2 weeks after, like it increased. There was a dull ache after the RCT, but the pain kept on increasing, and it's 4 weeks now, and the pain is so severe. That means option E, which can also be a cause of a severe pain, but it's the cause of an immediate severe pain while you're doing the RCT, not 4 weeks after you have done the RCT. So the only plausible solution is that the solution did not clean the canals properly, which means the bacteria were still left in the canal, and it's those bacteria, because they have still been left in the canal, are causing infection now. Understood? Understood how I explained you? You want to pause, go back, listen, and come back again. So it's like, I'm catching my nose like this instead of straight here. This is what this question is. It's just taking you round and round. But it's a pretty straightforward question. So the canals have not been cleaned properly is what it's being said. The solution concentration of hypochlorite is not a problem here. 2% is a decent solution, unbuffered one, that too, high concentration. Always use that under rubber dam. Okay. Now, you noted from the clinical records that the previous dentist used gutta-percha cones and zinc oxide eugenol sealer in a lateral compaction technique for tooth forceps. Which root filling related factor contributed most likely to endodontic treatment failure? Okay. So, like I mentioned, if you have not, the first factor always in an RCT failure is maybe you missed a canal. Basically, you missed a pulp to be removed. If that is sorted out, then probably irrigation has not happened properly. Now, that is still sorted out, then it has to do something with the gutta-percha and the filling. Though the possibility of it causing a reinfection or pain is less, but still if you want to focus on the obturation, then let's go back to the x-ray. What do you see here? Distally out here, the gutta-percha has not gone properly. Now, why do we relate the patency of the canal so that the gutta-percha can reach the apices, and if it is short, we think, it's a root canal treatment failure. Why? See, when you are doing biomechanical preparation and you're going all the way till the apex, you are making the canal open, you are cleaning it properly. If you have done that, the gutta-percha will go till the apex. When you see a short obturation, it's by default, we assume that the cleaning has not been done properly. The mechanical preparation of the canal has not been done properly. And because that has not been done properly, that is why the gutta-percha has not gone till the apex. Which means that the level till which the gutta-percha has gone, beyond that till the apex, like for example, if I take my arrow out here, this particular area has been not cleaned properly, and that's why the gutta-percha did not go. Now, if it's not been cleaned properly, that means there is still remaining persistent infection, and that is why the patient is still having pain. So we are relating the gutta-percha not going till the apex with the possibility that that much area has not been cleaned and prepped properly. You understand? That is why this question is asking Which root canal filling factor contributed most likely to the endodontic treatment failure? And the answer is the incomplete root canal obturation. There can be possibilities where the apex has been cleaned and prepped properly, and yet while probably burning off the gutta perca, it just came off a little bit, and that's why it's not seen till the apex on the x-ray. But in those scenarios, the patient will not have pain because the canals are cleaned, they are prepped, there is no infection remaining. So even accidentally, if you discover in somebody's mouth a short RCT obturation and the patient says, but doctor, I've been fine with it since the day it was done, it's never given me a problem. You don't see any widened PDL space, you tap on the tooth, you do anything and the tooth is just happy. Even though the obturation is short, it's okay because probably the canal was cleaned properly. But when you have a case where there is severe pain and there is short obturation, then you have to assume that that much space where the obturation is not there, probably it's been not cleaned. You understand? Simple. Now, you notice a radiolucency in the furcation of Rajesh's tooth forceps. Okay, here, basically this area. What complementary imaging modality is the most accurate for diagnosing this lesion? Now, here the keyword is most accurate. The most accurate imaging modality will always be CBCT. You have it or you're not. The question is asking most accurate. So close your eyes and choose CBCT. Okay. It's not which is the initial radiograph you're going to take or what you're going to do to maintain your records. No. The question specifically asked the most accurate, CBCT. When CBCT was not there, you would have still relied on periopacal radiograph with a tube shift or something. But with the advent of CBCT, you're going to go with that, right? Last question for today. You are unable to provide Rajesh with dental treatment within the next 48 hours. Oops. So you're busy or whatever, and for the next 48 hours, you just cannot help him. Basically, how you will be helping him, either you would remove the tooth off or you open it and you remove the gutta perca and probably give a sedative dressing or do whatever, but somehow you just cannot do it. So now which painkiller you're going to give him, because he's in severe pain and you cannot just send him out of your clinic without giving anything. Now you remember his medical history is having a GI ulcer. So which medicine are we going to give? Ibuprofen and codeine. Brufen is out. No. Celecoxib and codeine. Celecoxib is a selective COX inhibitor. No. Paracetamol and celecoxib. Celecoxib again in the option no. Celecoxib and oxycodone. Again celecoxib in the option no. Oxycodone and paracetamol, yes. See, I'm not saying ibuprofen and celecoxib are contraindicated, but they are to be avoided. There is a big difference between contraindication and avoid. If there was no other option of oxycodone, then probably I would have chosen celecoxib and oxycodone. I mean, oxycodone and paracetamol. If option E was not given, then my option could have been option D. But since I have the option E, I'm going to choose that because I will try and avoid celecoxib and other NSAIDs because they do aggravate an existing GI ulcer, or they can just lead to an GI ulcer. So since we already know the medical history, I'm going to prefer option E. But if there was no history of GI ulcer, then I could have given option A, B, C, D, anything, you know. So this is how it is, and exam is right around the corner. I think just a week to go. Very important question. There are going to be many questions like this in exam. There are going to be many scenarios like this in your life, and you have to tackle this and feel a lot of empathy for those patients who come with so much severe pain and in spite of having a root canal done, you know. As it is, doing a root canal is so traumatic for so many, and then just getting to know, oh my god, I have to do a re-root canal on the same tooth is further frustrating. And least of all that you want to know that, oh my god, the furcation area has been fractured. My god. I mean, this is a nightmare for the patient. So you have to be so empathetic. You have to be so compassionate towards such patients. yeah, these are the skills that you need to develop. Like, not just be a trained dentist, you have to be a good doctor. So anyways, I hope you enjoy this video. Looking forward to your comments, and yes, just going through this book. Anybody wants this book of Ultimate ADC Companion book, which has so many subjects given by the ADC resource, you can just email me and I will forward you the sample copy of this, as well as I'm happy to forward you the sample copy of comprehensive book, which has 440 scenario-based questions from ODEL, therapeutic guidelines, infection control, ethics, consent, COVID-19, and public health dentistry. You can go through these questions, and if you require the book, you can just email me again. This is basically question bank for ADC exam, which should help you out. So have a nice day. Bye-bye.